Way.
All
So,
right.
hi everyone. Happy Sunday. I hope everyone, wherever you are, has a little bit of sunshine, which we never really have here in Southern Ontario. So, if you don't know me, my name is Misha Appel. I'm the eldest daughter of Eve and Luba Appel, and I'm filling in for Cantor Baruch. We're really excited to be joined here today by Dr. Yonina Mar. So, a little bit about Dr. Yonina Mar. She grew up in Hamilton, attended our lovely Anshe Shalom with her parents, Hinda and Mark Levine, and her brother, Oren Levine, who are all on the Zoom today. She received her medical degree from Imperial College London in England, and then returned to Hamilton to complete her residency training in family medicine at McMaster University. During her residency, she grew an interest in inner city health, which led her to pursue a fellowship training in addiction medicine at the Addiction Institute at Mount Sinai in New York City. She currently works as a medical director in one of Mount Sinai Beth Israel's opioid treatment programs, which is a methadone dispensing clinic in the Lower East Side of Manhattan. She also works as a family doctor in a harm reduction clinic in Harlem, where she provides comprehensive medical care for patients that use substances. Besides clinical patient care, she's actively involved in teaching medical students, residents, and fellows, helping to instill an understanding and appreciation of addiction. At a policy level, she also sits on the New York State Substance Use Guideline Committee and has written and reviewed guidelines geared toward generalists and specialists to help improve care for patients that struggle with addiction. We are very lucky to get the next hour or so with Dr. Mar. So without further ado, take it away.
Thank you for that introduction. So I'm actually quite honored to be here today. I have my parents, as you guys know, have been attending the Breakfast Club for as long as I can remember. So being able to speak to them and for the Breakfast Club today is really quite an honor. So thank you for being here. And I know I also have some friends and family joining as well, which is wonderful. So thank you all for being here today. So as mentioned, I live in New York City. I am now working in New York City. I work in the Lower East Side of Manhattan in an opioid treatment program, which I will sort of here and there probably change terms, but an opioid treatment abbreviated OTP, so shortened OTP, is a methadone dispensing clinic. And I will get into a little bit more, obviously, about that in my talk. And it's a bit different from Canada, so that term might not be familiar to you because they don't have them in Canada. I also work in a harm reduction primary care clinic, so again, that's sort of a family medicine, adult medicine, primary care, what we sort of in Canada be more familiar as family medicine. So I am going to talk today about the opioid crisis and my work treating patients with opioid use disorder. Starting here with this title slide, I chose a photo for the slide. It's a photo from a recent article and an opinion piece in the New York Times, very extensive article, well-researched article by someone named Janine Interlandi. And this was one of the photographs from the article. And I think it resonates with me because I think it really highlights a couple of sort of things. I think in this picture, the picture really captures sort of a moment of connection and compassion between what looks like they're a patient and a provider. And I think these things are really fundamental in treating patients with opioid use disorder. And it's certainly the way I practice. I also just wanted to share a brief anecdote of how I got involved in addiction in the first place. And I think sort of, again, this picture emphasizes that empathy and connection. And I think we tend to, as a society, still hold a lot of stigma against people who struggle with opioid use disorder and struggle with addiction in general. And what actually led me into the field was one particular sort of, I can point to one particular moment in time, and I was in residency and doing an elective with some doctors who worked in addiction, and I was in sort of the equivalent, a little bit of an opioid treatment program in Canada, in Toronto. And I was told to be there early, and it often opens, medicating starts very early, often at 7 in the morning. And I was there early, and the only other person that was there, and I guess the clinic had been open, so someone must have been somewhere, but it was myself and a patient in the waiting room. And we got to chatting, and through our conversation and through sort of kind of what that patient shared, he was very warm, very chatty. He was just sort of like a regular guy. And I realized in that moment how many inherent biases and stigma I actually held. And that experience was so eye-opening for me. And I realized that really that we hold so many preconceived ideas. I held preconceived ideas about what heroin use was like, what opioid use disorder was all about. And people are just regular people, a lot of these people, and often they've experienced a lot more hardship in their life than maybe the average, but they're just regular people. And I think as a society, we have to remember that, and we should continue to work towards eliminating stigma. And I would argue that one of the best ways to break down stigma is to educate. And that's what I'm going to try and do here for you today. Okay, so just at some point, if anything kind of technical difficulties go wrong, or you can't see my slides or something, please do interrupt or just say something if there's any issues. Can you see my objective slide right now?
Yep, all
Great.
good.
Good. Okay. So this is sort of an outline of what I want to try and cover. I want to give you an understanding of how opioids work. Many of you probably do understand, but I'm just going to give you a quick overview of that. I'm going to talk about the backstory of the opioid crisis and a bit about the OxyContin story and the Sackler story. I'm going to sort of get into what is opioid use disorder, how we manage it, some of the challenges of the current crisis, touching on fentanyl and xylazine, which you may have heard of about now too. I know it's made its way; it's in the Canadian news as well. I'm going to talk about harm reduction and what it is, with a particular example case. A little bit on the US versus Canada approach, and then I'm going to leave you with some thoughts on where do we go from here. All right, so hopefully this works. This is a little video. I hope you can hear the sound. Again, please interrupt if there's any issues. Right. Right. Here.
Effective painkiller today. To understand why opioids are so addictive, it helps to trace how these drugs affect the human body.
You
From
can
the
hear?
first dose through repeated use to
Yes.
what happens
Great.
when long-term use stops. Each of these drugs has slightly different chemistry, but all act on the body's opioid system by binding to opioid receptors in the brain. The body's endorphins temper pain signals by binding to these receptors, and opioid drugs bind much more strongly for longer. So opioid drugs can manage much more severe pain than endorphins can. Opioid receptors also influence everything from mood to normal bodily functions. With these functions too, opioids' binding strength and durability mean their effects are more pronounced and widespread than those of the body's natural signaling molecules. When a drug binds to opioid receptors, it triggers the release of dopamine, which is linked to feelings of pleasure and may be responsible for the sense of euphoria that characterizes an opioid high. At the same time, opioids suppress the release of noradrenaline, which influences wakefulness, breathing, digestion, and blood pressure. A therapeutic dose decreases noradrenaline enough to cause side effects like constipation. At higher doses, opioids can decrease heart and breathing rates to dangerous levels, causing loss of consciousness and even death. Over time, the body starts to develop a tolerance for opioids, It may decrease its number of opioid receptors, or the receptors may become less responsive. To experience the same release of dopamine and resulting mood effects as before, people have to take larger and larger doses, a cycle that leads to physical dependence and addiction. As people take more opioids to compensate for tolerance, noradrenaline levels become lower and lower, to a point that could impact basic bodily functions. The body compensates by increasing its number of noradrenaline receptors, so it can detect much smaller amounts of noradrenaline. This increased sensitivity to noradrenaline allows the body to continue functioning normally. In fact, it becomes dependent on opioids to maintain the mood balance. When someone who is physically dependent on opioids stops taking them abruptly, that balance is disrupted. Noradrenaline levels can increase within a day of ceasing opioid use, but the body takes much longer to get rid of all the extra noradrenaline receptors it made. That means there's a period of time when the body is too sensitive to noradrenaline. This oversensitivity causes withdrawal symptoms, including muscle aches, stomach pains, fever, and vomiting. Though temporary, opioid withdrawal can be incredibly debilitating. In serious cases, someone in withdrawal can be violently ill for days or even weeks. People who are addicted to opioids aren't necessarily using the drugs to get high anymore, but rather to avoid being sick. Many risk losing wages or even jobs while in withdrawal, or may not have anyone to take care of them during withdrawal. If someone goes back to using opioids later, they can be at particularly high risk for overdose, because what would have been a standard dose while their tolerance was high can now be lethal. Since 1980, accidental deaths from opioid overdose have grown exponentially in the United States, and opioid addictions have also exploded around the world. While opioid painkiller prescriptions are becoming more closely regulated, cases of overdose and addiction are still increasing, especially among younger people. Many of the early cases of addiction.
All right. So that hopefully gives you a nice little overview, and probably, as I said, most of you know that some of that information, but that's sort of the fundamentals in trying to understand opioids, and I'll come back to some of those concepts throughout my talk. So here on this slide, this is a graph that shows the 3 waves of overdose deaths that we often talk about. We often talk about it in 3 waves. And at the end of that little video clip that I was playing there, you saw the graph and you saw sort of how the overdoses start increasing. Here, so in the first wave, which I'm going to talk about first, it's a rise in prescription opioid overdose deaths, and that really started in the 1990s. And that really can be directly linked to the OxyContin story. So I'm going to come back to the second and third wave a bit later. I'm going to start with talking about the first wave. Okay, so just a few statistics, just to give you some of that sense of what these numbers are like. Sometimes it's sort of overwhelming to see just sort of statistics and numbers. That's why I kind of included that picture at the bottom to give you a sense. That's from the CDC. And this is, again, we're talking about US data here. But 220 people died each day from an opioid overdose in 2021. And that's just sort of obviously a bit mind-boggling how many people are dying. From 1999 to 2021, nearly 645,000 people died from an overdose of an opioid. And that was sort of included in that. That was illicit opioids like heroin, and those were prescription pills as well, sort of everything all together. And just to give you that reference point, so 6 times higher than the number in 1999 by 2021. Nearly 107,000 people died of drug overdoses in 2021. Certainly COVID had a bit of an impact, and not a bit, a big impact. death rates, overdose rates increased over and have continued to increase as well. During COVID, more people using in isolation, some treatment programs were closed, and we saw that increase happen. Specifically, synthetic opioid involved death rates increased over 22% in that year from 2020 to 2021. And we saw a decrease in heroin involved death rates. And that's really because so much more of the drug supply was fentanyl compared to heroin. And really, it's, as I often say to patients, it's like heroin it's not heroin anymore. I don't even really say heroin, I'll say heroin / fentanyl when I'm talking to patients about their use. We rarely see just patients come up positive for opiates, where heroin would give us a positive for opiate. We sometimes don't even see that. Fentanyl comes up differently on toxicology as a synthetic opioid. It gets measured in toxicology differently. And we can see there, so prescription opioid involved death rates remained the same. So I'm going to start talking here. This gives you a bit of a timeline. I'm going to touch on some of these different points in my talk. You can see sort of methadone administration had already started in the 60s, just coming out of the 70s and 80s in the US, the war on drugs. It was very much a crackdown on and stricter rules and stricter penalties for drug use and drug possession. And then I'm going to talk about the OxyContin story in the 1990s, and sort of coming out of that sort of background on war on drugs. Sort of interesting to see the phenomenon of all this sort of this wave of sort of overprescribing and just amount of opioids, and that really was starting to increase in the US. All right, so I've included here a picture of, and this is a picture from an article, and it was this article by Patrick Radden Keefe that came out in the New Yorker in 2017, which was actually sort of excerpts and parts of his book that was called The Empire of Pain. This is sort of drew a lot of attention and the public sort of became much more familiar with the story of the Sackler story and sort of the OxyContin story. And it was an incredible article, actually. And I'm not sure if any of you have read the book, but it really kind of goes into detail about the Sackler story and the Purdue story and the OxyContin story. And I'm going to kind of summarize some of the key principles and points from the story and the FDA's failure, really, as well. So basically, Purdue Pharma, owned by the Sackler families, developed OxyContin in 1995. And they marketed it as a long-lasting narcotic for moderate to severe pain in 1996. And this is sort of relevant because opioids up until that point really had been sort of thought of as really, this is for severe pain, this is for cancer pain, this is not something to be using for moderate pain. And that sort of thinking changed a little bit with this OxyContin that came out. I've put it in red there, and I really want to highlight this. The FDA approved the package insert to say that delayed absorption, as provided by OxyContin, is believed to reduce the abuse liability. And that was really Purdue Pharma and the Sackler family, really, they capitalized on that. The fact that they could then go on, and they did this to say that it was essentially non-addictive. And there's sort of some of what's come out in the whole story and the court cases and sort of what lawsuits have looked into. They found that Purdue actually instructed representatives to assure doctors repeatedly and without evidence that fewer than 1% of patients who took OxyContin became addicted. And that was just not true. And the lawsuits later revealed that that was not based on clinical trials. That was really not based on anything. And similar really to any other opioid, it was certainly addictive, and certainly people could develop dependence. And in fact, Purdue claimed that the drug lasted 12 hours and that you only needed to take it twice a day as an extended release formulation, but it didn't last that long. And it only lasted really for most people 6 to 8 hours. And that really sort of kick-started things in terms of it created a scenario where people were prone to overusing them because they would run out, or their symptoms would come back early, not at sort of that 6 to 8 hours, that resulted in withdrawal symptoms. And again, as you saw in that little video, it's sort of that is basically in those sorts of situations, people tend to take more. So it resulted in a lot of overuse. I just captured there in yellow, I'll read them out to you, a couple sort of excerpts from the New Yorker article. And so I'll read them out. The crisis was initially precipitated by a shift in the culture of prescribing, a shift carefully engineered by Purdue. It's in 1996 that prescribing really takes off. That was the year Purdue launched a multifaceted campaign that misinformed the medical community about the risks. And then also the marketing of OxyContin relied on an empirical circularity. The company convinced doctors of the drug's safety with literature that had been produced by doctors who were paid or funded by the company. So you can see just the corruption there, and just sort of just how things were set up to fail, really. So just highlighting the FDA's role in all of this. A few key things sort of happened and failures really on the FDA, the part of the FDA. So they approved OxyContin based on only one study. And even within their own regulations, they say that there needs to be at least 2 well-designed clinical trials. And so they used one, and it wasn't even really a very good trial. It was a 2-week study around patients with osteoarthritis. Yeah. They also approved OxyContin for a broad indication, which allowed Purdue to promote its use for common conditions. And again, getting at that sort of moderate to pain, not only severe pain. And this created a situation where really there was more harm created than help. Another key thing was that 2 principal FDA reviewers who approved Purdue's application took positions at Purdue within 2 years. So again, highlighting the corruption. They also use and they continue to use this methodology for opioids, actually, which is interesting. The EERW, which stands for Enriched Enrollment Randomized Withdrawal. And basically it's sort of thought of as really it's a situation of cooking the books. It's based on private meetings between FDA and pharmaceutical companies. So the methodology has errors as well when they're looking at studies. Also, FDA Advisory Committee had ties to pharmaceutical companies, and they advised against narrowing the indication, even as overdoses started to rise. But just to give you a sense of how big a problem, by 2013, enough opioids were prescribed to provide every adult in the country, in the US, with a full pill bottle. So huge amounts of opioids being prescribed. And then one last point I just wanted to leave you with, in 2017, in the President's Commission, there was, as they investigated, they really stated that there was an inadequate oversight by the FDA. So this, again, another excerpt from Patrick Radden-Keefe's article. Everywhere OxyContin spread, addiction followed. It seemed as if the problems associated with OxyContin were metastasizing like a cancer. Okay, so back to this slide for a second, because here I'm going to really get into wave 2, the rise in heroin and overdose deaths that started in 2010. And this was really a knock-on effect of the first wave. What had happened in the first wave, the overprescribing, the amount of prescribing that was happening. And then as overdoses started to rise, doctors started to kind of reel things in a little, and some doctors stopped prescribing. There was also starting to be more of a crackdown on overprescribing and inappropriate prescribing. And then meanwhile, also patients who were overusing and no longer and running out early these all sort of created situations where patients and people went to the streets basically, and they started buying illicit pills, illicit opioid pills like OxyContin, oxycodone, other things. And this is actually not financially sustainable for very long. They are much more expensive than heroin on the street. Just to give you an example, and this is, I was speaking to a patient the other day who was using oxycodone on the street, which we likely think is fake press pills, which we'll get into a little bit later. But he told me that he was paying $30 for one pill, one oxycodone pill. And heroin these days in New York, and it's similar in Canada, costs about $5 to $10 for about the equivalent amount of a pill. And if not more, you would get more heroin for sort of the equivalent amount. And so big difference in price. And so really just financially not sustainable to buy pills on the street. And that's where sort of that starting to use heroin comes in, because at this point people are dependent, they need it. Otherwise they go into withdrawal. And as you saw in the video, the withdrawal symptoms are often horrendous for people. They feel like they're going to die, even though they're not. And it's a very strong drive to use. So that sort of, I often get asked the question sort of, well, how does someone get to the point where they start using heroin? And that is sort of that's really when they are so driven by such severe withdrawal that they'll do anything. And that's how they start using heroin. Because really a lot of patients that I do see started with prescription opioids and transitioned into heroin. All right, so again, just to reiterate what you saw in the video, tolerance is you need more to get the same effect. Withdrawal is when you stop it abruptly or reduce it significantly, you're going to experience some of these symptoms: pain, chills, feeling hot and cold, feverish, cramps, diarrhea. Dilated pupils is something we observe, we see that. Restlessness, anxiety, nausea, vomiting, insomnia, intense cravings. So really you can see these patients are miserable when they're in withdrawal. And when we're dealing with the concepts of tolerance and withdrawal, we're getting into that territory of physical dependence. Okay, so this slide shows the criteria for diagnosing opioid use disorder. And the first set, so everything except the last two really gets at sort of cravings and also in disruption of day-to-day functioning. The last two, tolerance and withdrawal, which I just explained, are more dealing with the dependence component of it. You do only need 2 to 3, so technically you could just have tolerance and withdrawal. That would be mild, and then you sort of 4 to 5 criteria met, moderate, and 6 or more is severe. Most of the patients I see are really, it's severe, 6 or more symptoms they're meeting criteria for. And I highlighted the withdrawal, just again, as I keep reiterating, it's the withdrawal that really drives ongoing use. It's the avoidance of getting sick. That's what really perpetuates it. So another thing that I want to touch on, and it is the fact that we think about opioid use disorder now as a chronic condition. We didn't always. We really, for the last few decades, we have. Before that, there was sort of much more thinking around the fact that this was a moral failing. This is sort of, we can fix this, just sort of snap out of it. What's wrong with people? And over time, we've come to realize it's much more of a chronic disease. And it's recognized in the medical world as a chronic disease. It's complicated. We don't totally understand why, but certainly there are changes in brain chemistry and function. And it is really a complex interplay between biological and environmental factors. I often sort of describe it as a perfect storm of a situation. Many patients they've grown up around substance use. It may continue to be prevalent in their environment. Example, I have quite a few patients who are in the shelter system because they have unstable housing, and the shelters are notorious for having drug use. So they're around it, they're around people that are using it, they're around the paraphernalia. And so it's sort of, when you're always around it, it's hard not to use. So also, patients often have significant stressors in their life, currently, also in the past. And I just sort of want to emphasize that there's often a very significant trauma history. And then you kind of throw in some mental health disorders and maybe some complex medical issues, and you really have a sort of perfect storm of a situation, and it helps you understand like how people get to this point. With patients, we often talk about, they say too, sort of people, places, and things as triggers. So a couple stats there: 3 to 19% of people taking prescription opioids develop an addiction to them. And 45% of heroin users started with prescription opioids. There is no cure, and really long-term management is what's required for treatment. Sometimes we compare it to things like diabetes and hypertension, and generally in those sorts of illnesses, once you're at the point where you need medication, these are generally going to be long-term, sometimes lifelong medications. We think about opioid use disorder now in a similar way. So this is actually, I just want to read this to you. It's a excerpt from Janine Interlandi's New York Times opinion piece. And I think it really kind of, again, captures it with quite some emphasis there, what the situation is like. So I'll read it out to you. In many ways, addiction is like any other chronic medical condition. It involves periods of remission and relapse. It can be fatal, and it is often manageable with the right support. Several unique barriers, however, make substance use disorders more difficult to treat. Some people cannot see that they have a problem. Others recognize the trouble they're in, but are too ashamed or afraid to ask for help. The fear is understandable. Even when they are in recovery, people who admit to struggling with drugs or alcohol, or who take medications to manage addiction, can lose jobs, lose housing, lose custody of their children. They can be denied care in nursing homes, be denied nutritional assistance, be denied organ transplants. They can be judged, be shamed, and perhaps worst of all, be ostracized by friends and family members whose support they desperately need. And a few lines down, it sort of highlights the fact that these are problems that most other illnesses do not face. I would say there's sort of one other kind of caveat to that, and I would say mental health disorders face similar sorts of issues, but really it's not, it's a bit sort of unique, I find, to addiction and mental health, that you sort of see these barriers and challenges. All right, so thinking about treatment options for opioid use disorder. I, again, have a little thing I wanted to highlight. Again, a little line from Janine Interlandi's article. It's also a matter of timing. The window when a person with substance use disorder is willing and able to accept treatment can be vanishingly small, in part because withdrawal itself is often unbearable. And I find in practice that's absolutely true. It's hard sometimes to capture a patient when they're ready for change. At times, there's a small moment in time where we can get going and really sort of get them off to kind of continue treatment. And that's a challenge, again, that not all other areas of medicine face. The style of interaction that we often use, it's an evidence-based approach, is called motivational interviewing. Works very closely with the stages of change model. So basically, we're trying to get patients to the next stage of change. So for example, if they're pre-contemplative, we're trying to get them to the contemplative stage. And sort of there's several levels, and ultimately kind of action is what we're going for. So we use open-ended questions, affirmations, reflections, and summaries in our interactions with patients. And it really highlights this approach is normalizing ambivalence, and really kind of working with patients with where they're at, and sort of just recognizing that often patients are unsure, they're ambivalent about what they want to do next. And it sort of takes that into account. We have 3 approved medications for treating opioid use disorder. That's methadone, buprenorphine, naltrexone. There's also evidence to show that psychosocial modalities of treatment work well as well, so ideally in combination with the motivational interviewing and treatment as well. And those psychosocial modalities that are evidence-based are things like 12-step programs like Alcoholics Anonymous, Narcotics Anonymous, also groups and individual counseling. And one thing I also just want to highlight here is all these medications are, well, actually, I should say methadone and buprenorphine, which are opioid replacement medications, they are long-acting medications. And for patients who are using heroin or fentanyl, these are generally, they don't last very long in the system. And so often their day is taken up by continuing to use. They may feel comfortable for a few hours and then they have to use again. And so methadone and buprenorphine really are long-acting, and generally patients only need to take them once a day, and when they're at a good stable dose, and they will feel comfortable and not go into withdrawal. So here I've just have on a graph, have shown you these 3 medications. You can see naltrexone along the bottom. It's an antagonist, so it blocks the opioid receptor. And so you do not get an activation of the receptor. Then you see buprenorphine in the middle one there in orange, which is a partial agonist. It's going to bind and activate the receptor partially. It's very sticky for the receptor, and it's often enough for many people to work very well and to keep them from going into withdrawal and to eliminate their cravings, and therefore thus being able to stabilize them and eliminate the use. You can see it's below, it sort of has a ceiling effect below the threshold for respiratory depression. So it's considered a safer option because of it sort of essentially has no risk for overdose. The other opioids, methadone included, and pretty much all other opioids have, you can see that dose, the relationship between the activation of the receptor and that drug dose. So as you go up on the dose, you're going to get more activation of the receptor, and then you get into that territory where you run the risk of respiratory depression, which is ultimately, that's how people die of an overdose, is they stop breathing. And that concept of that risk is ultimately what is sort of makes it very a lot of the rules around methadone, particularly in the US, because of that safety risk of overdose. And that's why it's so highly regulated. So this slide I'm going to start talking about methadone now, and this is sort of the methadone beginnings are quite interesting to me, and part of that I think is because it all started at the institution I work at Beth. So I work in the Mount Sinai system in New York, and I'm affiliated in terms of my opioid treatment program work with Mount Sinai Beth Israel. And methadone maintenance started at Beth Israel, and so which I think is pretty cool, that history. It was started by Dr. Vincent Dole and Dr. Marie Niswander. They were a husband and wife team, and they developed methadone maintenance. And Dole developed methadone in the detox. He developed methadone detox in the New York City jail system and office-based methadone maintenance with his wife. Prior to their collaboration, Niswander had worked for almost 2 decades treating narcotic addicts in various venues, and she was also the founder of Narcotics Anonymous, actually. And one of the things that was really kind of key with them is that they thought about addicts as patients. And this was a revolutionary concept at the time, because really addiction had been relegated to the criminal justice system. So the fact that they were progressive thinkers at the time, so early in the 60s, and had their visions, really, they had it right from the beginning. And Niswander really kind of concluded in her work that the groups and the meetings and maybe counseling, that was not enough to alleviate cravings, which for many was the focal point of leading to relapse. And she felt, and again, working with Dole, they felt that there needed to be some sort of replacement, a sort of a harm reduction approach that where they could give an opioid, a longer acting opioid, to replace what patients were using. And so they started this pilot project in 1964, and it grew from there. And really, their real achievement was to shift the paradigm of addictive behavior from a moral, stigmatizing psychological failing to a chronic metabolic disease. Herman Joseph is a very prominent social psychologist researcher. I liked this quote from him. Dr. Dole was always at the service of patients and advocacy groups to help resolve issues of stigma and misdirected policies. And again, this quote here on the left side is really Dole really felt that it was a medical disease and therefore the responsibility of the medical profession. The other picture I've included there is a picture of Dr. Melissa Freeman on the left, and she was the first doctor to treat heroin-addicted women with methadone, and she joined Niswander and Dole along with some other early doctors in sort of starting the evolution of methadone. And in that picture, you can see another man, and this shows that actually she was the granddaughter of a slave who was emancipated when he was a child, almost a teenager. And I included her too because she is, I feel very proud and humbled to be sitting at her desk. She was, the clinic I work in was her clinic from the 60s until just a few years ago. She worked into her early 90s, which was incredible. This was really her baby. Like she really was so passionate about her work. And so I'm very honored to be continuing and sitting at her desk. So methadone, to give you more of the specifics, so it is an opioid replacement therapy. It prevents withdrawal symptoms. It reduces cravings. It can produce euphoria. Obviously, that's not the goal, but that can happen. It can cause respiratory depression, and so we're obviously trying to avoid that. It's available in specially regulated clinics in the US called opioid treatment programs with observed dosing. You earn takeouts, and if you're still using opioids, generally the rule of thumb is you're going to go up on the methadone dose. It can be a bit risky for overdose when combined with other central nervous system depressants, downers like alcohol and benzodiazepines. Benzodiazepines are things like Xanax, Klonopin, Ativan, that sort of thing. So we have to be much more cautious in those situations. So one of the things, and I'm going to play another short clip, that has been a real challenge in the US is sort of, even though Niswander and Dole had these sort of very progressive thoughts and thinking and really destigmatizing goals, it's sort of over the years that we've been working with methadone, it still has remained very stigmatized, and in the US, very difficult to get still. And as sort of, you see that line there, methadone is one of the oldest and most effective treatments for opioid addiction, and it is still more difficult for most Americans to obtain than a bag of heroin. So I'm going to play this little clip. This is a clip from a documentary. It's a trailer to a documentary, to harm reductionists in New York, based in New York, made a film where they went around to 6 countries in the world, big spectrum of where they went. Some people doing a lot of harm reduction, and then the opposite. So where they went is the US, the UK, which has a system similar to Canada, which I'm going to touch on in a bit. Portugal, which is very harm reductionist, where they give methadone out of a mobile treatment van. And then the other countries they went were Russia, Afghanistan, and India. India sort of had a bit of a makeshift treatment programs with methadone, and Afghanistan and Russia have nothing. So I'm going to play this quick clip for you here.
In America, do they help people?
It's a medication. It's not a drug. And that's a big misconception. People think that you go there just to get high. And that's not why we're there. We're there because we want to be clean. We want to have a job.
It's the only drug that you cannot get from your doctor, that you cannot get at a pharmacy, that you have to go to a special clinic during special hours and be observed taking it. I don't know anything other than stigmatizing to say about that.
Nobody knew the horrific power imbalance that went on in the average methadone clinic.
It's really difficult to protect yourself from the police abuse, for example, or protect yourself from going to prisons.
They don't have any treatment in Afghanistan. They need treatment.
These patients are quite manipulative. Sometimes I know that they have work to do. They have a job, they have a life. And I have to still tell them to come and take treatment here every single day.
This place is run like Rikers Island.
My benefits are cut off. They didn't pay us. You got to be weaned off the program. That's the horrors of a capitalist society.
I would not be here now if it wasn't for the methadone.
They have this frenzy in them, which they channel towards using drugs. And if they're able to channel it in the right place, they will be able to achieve a lot more than normal people would.
Our systems of delivering services to people have not shifted.
That's Portugal
along with
there.
our understanding.
The method I'm taking is not my identity. Okay, my identity is more. So you want to identify me and label me with a name of a substance that I'm using? You know what I mean? No. No.
I had to hide a part of Magda.
I'm a drug user activist.
It's nothing greater than living. We all want to live.
All right, so that gives you a little taste of some of the challenges and what people are up against and the way different countries deal with it. So next medication is buprenorphine, also an opioid replacement therapy. It blocks the effects of other opioids due to its high affinity for the receptor, and this can make it a little bit tricky to work with. But from when it does work, it works very well. It eliminates withdrawal symptoms, it reduces cravings. It doesn't really have a euphoric effect. It doesn't produce that high. And as I mentioned, it has that better safety profile due to the ceiling effect. So you can't really overdose on it and makes it much safer with downers. It can, because of its sort of safety profile, it can be prescribed in office-based settings. You don't need to give it in a treatment program like I do. We do give it there as an option, but we don't have to. It comes in sublingual films. You can see that's what it is in the picture. Also sublingual, so under the tongue tablets. Also comes in a longer acting injection and implant as well. So here, I won't go into too much detail, but just to give you one of the trickiness element to it is when you introduce buprenorphine and there's still a full agonist, something like, say, fentanyl or heroin around, it's going to bump it off the receptor because it's stickier for the receptor. It's going to displace it and bind. And again, it only activates it partially, which you can see there, about 50%. And so what ends up happening is there's this net sudden decrease in activation, and that is and people feel that as withdrawal. And the concept, the phenomenon of that is called precipitated withdrawal. And unfortunately, we have so few options to work with. And if patients experience precipitated withdrawal when they try buprenorphine, we often lose the opportunity to work with it because it's such an aversive experience and patients never want to try it again when this happens. And one of the challenges with fentanyl is that the fentanyl seems to hang around for longer. And so people are experiencing precipitated withdrawal sometimes multiple days after they've last used, which was not the case in the past with trying to start buprenorphine with patients who were using heroin or other opioids, which were in and out of the system much quicker. The fentanyl seems to hang on and be around still, which is making treatment much more difficult, harder to get patients to stabilize.
Dr. Mar, we have a
Yeah.
quick question in the chat.
Yeah.
Hoda Hasman is asking, what is agonist?
Oh, an agonist means that it binds to the receptor and activates it. So whereas an antagonist, which I'm about to talk about here, blocks the receptor. Is that clear? Does that answer the question? That's okay. All right, so next medication, which is a much more controversial medication, I would say it's not used nearly as much, is naltrexone, which is an opioid antagonist, so an opioid receptor blocker. It does come in an oral version, but what's recommended for opioid use disorder is the injection version of it, which is an injection every 28 days. It blocks the opioid receptor, therefore not activating at all. And really, it's just a built-in safety net. So basically, patients can't use, or sorry, if they use, they just won't feel it. So it can be good for someone who's really has the goal of abstinence. But if they're sort of on the fence, it's not ideal. I often give the example of a patient who I had worked with in the past who was very stable on buprenorphine, but he told the story of his daughter who tried to overcome the blockade of naltrexone and used and kept using to overcome the blockade. And eventually she did overcome the blockade and she overdosed and died. So it's really, you don't want this option for patients who are not sure what they want to do and are ambivalent. This is really for someone who very much, the risk of relapse is quite low. The other thing that makes it tricky is it can be difficult to initiate because you have to be opioid free, you have to be abstinent for 7 to 10 days. And just given how difficult it is for patients in withdrawal to stay abstinent, that's hard. So where this tends to work best is if patients are inpatient, they go in maybe for detox and stay for rehab, and then they're given this injection and at the end of their stay, and then with a plan to continue it monthly after that. All right, so the third wave is really the rise in synthetic overdose deaths, and which is really the fentanyl story. And that started in 2013. You can see there the arrow, and you can see how the graph, it really escalates quickly. So the fentanyl problem, really, it's been obviously in the news a lot for the last several years. It is a huge problem. It is a synthetic opioid. It is 50 times stronger than heroin, 100 times stronger than morphine, so very, very potent. There's a difference between what's on the street and pharmaceutical grade. It's been used, fentanyl's been used in medicine for a long time, pharmaceutical grade, and what we're seeing on the street is not diversion of that, it's man-made. We think it's being made in, or raw materials are coming from China, and then it's being manufactured in South Central and now North America as well. And it's ultimately what it has caused the massive increase in fatal and non-fatal overdoses. At this point, we can find it in most drugs. It's also sometimes in fake pressed pills. So sometimes what's sold on the street as a benzodiazepine like Xanax is actually just pressed fentanyl mixed with a bunch of other stuff. It's cheaper. It's more addictive. So you're getting people to come back, buy more. So it drives that economy there. And as I mentioned, it's much harder to stabilize patients on medication for opioid use disorder in this sort of era. I really have seen it change so much since I started training in it in 2017 in addiction. And I've sort of watched that story evolve. And it's a wild phenomenon that's happened, and it's challenging to stabilize patients these days, but when we get there, it is very rewarding. So another sort of contaminant that we're seeing is xylazine. Xylazine is actually not even meant for people. It is on the street known as tranq. So getting at the fact that it's a tranquilizer, it's an animal tranquilizer, in fact, and it's not meant for people. And these are sort of some excerpts from some of the DEA reports about the risks of fentanyl being mixed with xylazine, and it's sort of a public safety alert about it and how they're really finding it now everywhere. And this is really a phenomenon that has really just sort of taken off over the last couple years. It's been around for a while. It was an issue in Puerto Rico for a long time, but really in the other states, it started in Philadelphia really a couple years ago, and we've just seen it expand everywhere. And I know it's an issue in Canada as well now too. So a couple other just alerts from around issues with xylazine, and the fact that it isn't reversed by naloxone, the overdose reversal medication. However, given it's usually mixed with an opioid, the recommendation is still to give naloxone. The other big issue is what we're seeing is severe wounds, including necrosis, which is sort of rotting of human tissue, that sometimes leads to amputation of tissue. So this is generally seen in patients who are using the drugs IV, but not everyone uses drugs like heroin and fentanyl IV. A lot of people, in fact, more people I see sniff them. So an issue there too, but much more so with the people who are injecting. So a little bit graphic here, but this is sort of some of what we're seeing. I haven't seen anything this bad in my work, but I have seen something more like the bottom right corner shows an early onset ulcer, and that I have seen things like that for sure. So as I sort of said, not approved for humans due to the severe central nervous system depressant effects. And that's absolutely what we see. We see people very enhanced sedation and anesthesia, and it's being mixed in, and therefore, again, cheap, not scheduled. So it's sort of able to go kind of under the radar a little bit more. And as I said, not responsive to naloxone. So I'm going to touch a bit on harm reduction. I'm looking at my time here. I know I don't have that much time really left. Okay, if I continue for a little longer.
Yeah, I think we can go a little bit until you're finished, and people can drop off as they need.
Okay, thank you. So harm reduction, there is a distinction between sort of lowercase harm reduction and uppercase harm reduction. Harm reduction lowercase is sort of an approach in how to provide services in a non-judgmental, respectful way. And whereas uppercase harm reduction is more of a philosophical and political movement, really shifting power and resources to the most marginalized communities, and acknowledges also the history of oppression and racism and how much systemic racism there is in sort of the addiction story, really. I've put a little picture there of a book. Maya Salovitz is very much a harm reduction advocate, based in New York and also LA. And she's written extensively for the New York Times and also several books about it. She herself has a history. She's stable, very stable now, but had a history of drug use as well, earlier in her life. So here's some pictures of a lot of the harm reduction campaigns have focused on naloxone, which is the overdose reversal medication. You can see even on the bottom there, it says, "Don't trust your cocaine." So we're not only thinking about heroin and other opioids, we are acknowledging the fact that fentanyl is making its way into other drugs, and we need to be aware of it. And as you can see in that ad there, don't take chances, carry Narcan. So Narcan is the trade name for naloxone. So here up in the right corner, that's what it looks like. It's a nasal spray. It's evolved. It used to be more of an injection, but nowadays it's a nasal spray, very easy to use. You basically just stick it up the nostril and push it in, and you'll see within like a minute, basically someone who maybe have blue lips and not breathing will kind of wake up and be usually they're kind of upset and angry because they feel horrendous, because you're basically completely reversing it and taking off all the activation on the receptors. So they go into severe withdrawal right away, but it works. So when we're thinking about harm reduction, it's things like medication. Sometimes we think about things like methadone, buprenorphine as harm reduction because we're replacing an opioid with another opioid. There's also overdose prevention with naloxone, using less, not using alone. Example, trying to use with a friend or an acquaintance. Syringe exchange programs. So those are centers where you can get a lot of the gear and the equipment that you need to use. overdose prevention centers, which I'm going to just talk about here for a minute. These are essentially safe injection sites, widespread in Canada. They've long established in Canada. In the US, we have two. They're in New York. The reason there's only two is because they're federally illegal. It is illegal to operate in an establishment where you have use on site. And what ended up happening, so though it's been on the radar for many states, particularly liberal parts of the states, for a long time, they're so caught up in the federal legalities of it all. They've been very hard to open. De Blasio, our former mayor in New York, a couple years ago, before he on his way out, he basically secured local law enforcement such that they wouldn't shut the overdose prevention centers down. And they have remained open a little bit precariously, given they are federally illegal. But they're open and running, and there's two in East Harlem and also in Washington Heights, which is on the west side, north of West Harlem. Big sort of areas of a lot of drug use. And they are saving lives. They have served and helped thousands and thousands at this point since they've opened. And there has yet to be, though there's been many overdoses prevented on site, there has yet to be a fatality that has occurred at one of the sites. So there's a lot of evidence that they work, and hopefully we'll see more of them coming as things hopefully start to change in the US. So some of the supplies that can be available are things like syringes, needles, straws, cotton pipes, cookers, condoms. PrEP is medication for sort of exposure to sort of when there's risk of HIV. Other things where, again, sort of safe practices around sexual practices, so dental dams, lube, distilled water, which is needed for use, and many more. Xylazine, there's also test strips, which has been really helpful in the last couple of years. On the right there, you see a picture of, that's a fentanyl test strip. So you dissolve the drug in distilled water, and then you can use that strip and it will tell you whether there's fentanyl present, which is helpful to know. It's most of the time there is, but just nowadays there's xylazine strips too. So just patients can be, and people can be more aware and do other safe harm reduction practices when they're using. And the other thing I just want to highlight is trauma-informed care. So appreciating and understanding that a lot of these people have experienced trauma, and tailoring your treatment to sort of, and acknowledging and recognizing that. So I work at, where I do primary care is at a harm reduction center, primary care practice, where we really offer stigma-free care. And we really are working with patients who have a history of substance use, who may still be using as well. So it's a focused population, and I've outlined some of what the other goals of the REACH program. So again, stands for Respectful and Equitable Access to Comprehensive Healthcare. But we're not only trying to offer stigma-free care, but we're also trying to disseminate education and help the other healthcare providers around us learn how to work with addiction and how to treat patients effectively, and promote health equity as well. I'm lucky to really work alongside a wonderful team of providers at REACH. Doctors, nurses, social workers, patient navigators, who are people who kind of help get a patient from A to B without them slipping through the cracks, because this population tends to sort of do so a lot. And we are able to stabilize them often, and it's wonderful. And the gratitude that they sort of express is really next level. It's really a rewarding environment to work in. So I just want to give you a brief example of a patient that I'm working with at Reach, to kind of give you a sense of what this looks like in practice, what harm reduction looks like in practice. So Lee is not his real name. He's 19. He's one of my youngest patients because I only work with adults. Started using opioids intranasally at age 16. His parents were he's from a tight-knit family. His parents were very involved and supportive, and they kind of got him into a private rehab, to kind of get away from it all. He was given naltrexone. So again, that's the injection, that's the blocker. And so that you can't really use on top of that, or if you do, you won't feel it. So he got that at the end of his stay, as I mentioned, best given inpatient, because you have to be opioid free. But within a month, he had relapsed. He didn't find it helpful. He didn't like it. He found it sort of made him feel a little bit low as well. And within less than a month, he had started using again. So little while later, I would say some time passed. I think it's sort of his use continued for a couple years more. He came to the opioid treatment program seeking help. He knew about methadone. He thought maybe that would be a good idea. And when I met with him, I recognized here's a young man who has his whole life ahead of him. Let's try and really start with buprenorphine. Methadone is sort of, in some ways, as much as possible, we want to try working with buprenorphine first, if it'll work, just because of some of the complexities of methadone and the risks involved in it as well. So his case really involved a lot of care coordination, and I've highlighted that because I am a believer in, I think that is really a central concept to working with patients with addiction, is care coordinating, getting them connected to care, sort of having discourse with other disciplines and making sure that sort of everything is going to plan. So I was able to kind of organize with colleagues at one of the detox centers to admit him for inpatient detox, and they were able to start him on buprenorphine inpatient, which sometimes goes a little bit better, especially in the context of how tricky it is with fentanyl these days. We then made a plan for him to follow up at Reach with me, where I can continue prescribing the buprenorphine. And so I was managing his opioid use disorder, but also started to work on treating his depression, his generalized anxiety disorder, and his ADHD, which were also all a bit debilitating for him. Other team members that have been involved throughout, it's been the addiction psychiatrist as part of our Reach team, a buprenorphine nurse, patient navigator, social worker, and his family has been very much a part of this team approach. Some of the things that we're doing, and we're doing some, which we tend to do quite a bit in a harm reduction type clinic, is we do harm reduction prescribing. So things like, we will prescribe some medications that many other providers are really nervous to do, like benzodiazepines, because we will say, all right, well, we would rather someone take benzodiazepines that we are prescribing, and often it's the goal to eventually taper off of them in the future when they're more stable, but we'd rather have them using the real deal instead of the illicit benzodiazepines that are often fake, because that's what he had been using and they were likely fake. And then one of the newer things that we're going to add in, I'm about to see him on Tuesday actually, is we're going to start a trial of Vyvanse, which is a stimulant medication to help him with his ADHD. So just sort of summarized his case now at the bottom. So he's stable on buprenorphine. He has not used opioids for 2 months now. He no longer has cravings to use either. His depression and anxiety are no longer a burden, and he was able to start college courses 2 weeks ago. So things are really kind of looking up for him. And I'm only hoping that with that addition of the Vyvanse, he'll be able to focus even better in college and really kind of get going on living his life. So just a little bit on Canada versus US policy that's different. I've sort of touched on it a couple times through the talk, but one of the real key differences is the way that methadone is administered in Canada. Canada has a pharmacy-based methadone administration system. So a patient will go to a provider And they could be in a family health center, it could be their psychiatrist's office, really it can be wherever. And that doctor, as long as they've done the training, which is a sort of weekend-long training that CAMH runs in Toronto, and they have their sort of methadone essentially sort of license and training in it, they can prescribe methadone, and they prescribe it to a pharmacy, and the pharmacists manage the observed dosing and the takeouts. So generally, if they're doing well and they've stabilized in treatment, they can earn those takeouts. So it makes it much more accessible. Basically, patients can go to their neighborhood pharmacy, and the access is excellent. And by decentralizing it and by making it more accessible, you're also kind of dealing with this interesting issue that we have a big problem with in the US, and that is by centralizing it in the US, it attracts drug activity. So it's not uncommon for there to be a lot of drug transactions that tend to happen around a methadone clinic. They're often very discreet, the clinics, and so the public doesn't know that it's a methadone clinic, but certainly the dealers do. Drug dealers often hang around methadone clinics, and there's a lot of drug transactions that tend to happen. And that is the downfall of a centralized system like that. And really, though it happens somewhat in Canada, there are sort of pockets around sort of places, but by decentralizing it like that, you're really making a big difference in that issue. So the other thing, as I mentioned before, the overdose prevention centers, that's mainstream in Canada. You can go to a site and be able to use safely on site and have access to resuscitation. Those safe injection sites are the mainstay in Canada, and hopefully we'll see more of that here as well. Also, just Canada has been leaders in harm reduction. We often look to their work coming out west, out of Vancouver, a lot of progressive work being done there, a lot of sort of newer strategies to get people onto buprenorphine in the context of fentanyl. As I mentioned, it can be quite challenging. Something called micro-induction we use a lot lately, where we're starting lower on buprenorphine doses and building up slower than we would have in the past, in order to try and avoid inducing precipitated withdrawal and sort of those miserable effects that happen if you sort of start buprenorphine when there's still something in the system. So I'm happy to say that Canada is really a leader, and their harm reduction philosophies and progressive attitudes are really nice to see. So we continue to model and look to Canada for for guidance. So kind of getting to the end here, where do we go from here? So one of the things that Janine Interlandi in her opinion piece really emphasizes in her first section is humanize drug users. And that's sort of where I started with that picture of forming connection. And these are people, these are real people with real stories, often hard lives. And it's when you look at them as real people and you can humanize them, it really is so rewarding. And I think we need to, as a culture, remember that, and remember to humanize. Again, improving accessibility of treatment. So looking to Canada, the way they do it, we need to do better in that as well. There's still not nearly enough people getting the treatment that they need. Also things like community outreach, ER engagement, given it's so hard to capture people in their readiness to change and readiness to engage in treatment. Sometimes the best way to do that is to kind of go out into the community. And when patients come into the emergency room, sometimes it's trying to capture them at that point. And that's where something like the bridge clinic model works. And that's a bridge clinic model is basically trying to bridge them into care. So getting them at a point where they're in the emergency room, getting them started on a medication like buprenorphine, and then really supporting them to engage in care. And so really bridging them into engaging in treatment. Using a biopsychosocial approach, so really approaching it from all angles, the medication, the counseling, the engaging them in medical and psychiatric treatment if that's what they need. It's approaching it from all angles. care coordination with other medical and social disciplines. And this again is central to my approach. And I feel like some of the most rewarding cases that I've worked with are collaborations between other providers. Sometimes they're really difficult. Sometimes the overlap with other disciplines. Sometimes where it gets tricky is the overlap of pain and opioid use disorder, because that's very, very real. Though the structure of particularly in the US tries to divide addiction and pain and silo them, in reality, there's very, very much an overlap. One of my most rewarding cases of care coordination was with a patient who had metastatic prostate cancer, and working very closely with the oncology team and the palliative care team. And the patient just felt so supported. He was so happy with his care, and that we were all working so closely together. And though his journey was a difficult one, and he unfortunately has since passed, he was sort of really over the whole journey, really so grateful how the care that he received. And that was really because we were working together, and we were strategizing and dealing with some of the challenges all together. And it worked beautifully. So other things are educating trainees and physicians about what it is to work with addiction, and what are the sort of the key concepts in it. Breaking down biases and stigma, as I sort of started the talk with. We have a lot of work to do with that, and we need to continue working on that. Liberating methadone, so looking to sort of Canada's model, and hopefully sort of working to kind of to work towards a model similar to that. And it'll get there. I think at some point it'll change. It's certainly like there's progression that's happened a fair bit in terms of some of the changes that are happening there, but we have a long way to go. And another sort of more thing that we're looking to Canada for is more progressive ways to initiate buprenorphine, given it's so tricky these days in the context of fentanyl. So this is my final slide, and I give you that picture again, that picture of sort of connection and empathy. And I want to leave you with this final quote from Johann Hari, who gives a famous TED talk about addiction. And his line is, "The opposite of addiction is not sobriety. The opposite of addiction is connection." And I couldn't agree more. I think that connection is the way forward, and I will absolutely continue to strive for that in my practice. So thank you for listening, and if there's any questions, I know I've gone a little over time, so thanks for joining for that time. And yeah, I know there's only a few people. So
can I ask a question?
Sure.
Yeah. What about the use of Suboxone in
Suboxone?
Yeah.
Suboxone is buprenorphine. So
is it?
So I'm sorry I didn't make that more clear.
Yeah, because you'll see a lot of people ordered that. The other thing is, what about the role of the doctors? Like, what is being done to have the doctors not be so aggressive in prescribing narcotics? Some are, okay, not all by any means. Do you know what I'm saying? They're at least partly responsible for the opioid addictions in the States. So I just wonder what's being done. Is there any additional things being done to prevent, this sort of thing from happening from drugs?
For sure. There is absolutely one of the things that came out of the OxyContin kind of crisis was something that actually they don't really have in Canada yet, which I find interesting, but they certainly do in the US. It's called the Prescription Monitoring Program. And it's basically it's a way to monitor what doctors are prescribing in terms of controlled medications. And actually, as a prescriber of controlled medication, we are mandated to check this prescription monitoring program before we prescribe. So to see who a patient's getting medications from. And that was to sort of eliminate the doctor shopping that was going on very much so in the OxyContin era. And so this has been around kind of since then. And that really has changed things. And also beyond that, beyond monitoring sort of where prescriptions are coming from, there has also been a much more involvement of sort of the legal aspect of it. So even the FBI is investigating overprescribing. And so it has shifted. I often sort of say the pendulum has swung so far the other way. And that's why you now have these situations where providers, there's this complete sort of absence of prescribing opioids, even in situations where you would think, well, maybe it's okay for a bit or something. It's people refuse to prescribe because they're so afraid and they feel that someone is looking over their shoulder because of the overprescribing history, that now we have almost a situation sometimes of underprescribing. And so it sort of has had that interesting effect. Now you have a spectrum because some people you have some people who won't prescribe at all because they're too scared, and then you have other people that still there's the overprescribing. I have to say I have watched as some of those doctors have had their DEA licenses revoked so that they can no longer prescribe controlled medications, and FBI has shut down clinics and actually incarcerated doctors around overprescribing. And so there is the mentality and the approach now is that there has been a significant change and a crackdown on overprescribing over the last couple of decades in the US.
I got one more question about
Sure.
the manufacturers, you know, the Sacklers and the Purdue Frederick or whatever. What is the government doing? Should be okay in the States, but hopefully Canada, if we haven't done it yet, will follow to monitor what's coming out. You know, like when OxyContin came out or when they changed over, I can remember people said, well, that's not supposed to be addictive as opposed to what was oxycodone before. So I want to know, is there an additional monitoring of some of the literature that's coming out, or what's being said about the drug and the when these companies put out these medications?
Yeah, and I think I sort of touched on that in the beginning. And what's interesting is that to some degree, yes, there is that awareness of the history now that exists of the very sad and unfortunate story of what played out. And so people are much more in tune with that, and policymakers are much more in tune with that. And there is more oversight of it all. But as I kind of, to bring you back to that slide where I was talking about the failures of the FDA,
right?
One of the things I would point to is still the trials, the trial design that they tend to use for assessing opioids is fundamentally flawed. So there is that issue still that they're around sort of approving medications still seems to be somewhat of a corrupt situation. So it's interesting. So in some senses, I feel like there's been progress, and on the other hand, there's still some issues around some of the oversight that needs to happen by the FDA, for example.
Okay. Thank you.
You're welcome. Any other questions?
Do you have the same number of pain clinics as we do in Canada? And I just wonder if you could talk a little bit about their role and the types of things that they prescribe that are perhaps a lot safer than what patients might come across, even with their own physicians or trying to obtain on the street.
So it's an interesting question. I think so. I'm curious, sort of, when you say pain clinics in Canada, because pain clinics here in the US, there's quite a spectrum of what's on offer in pain clinics. You have some pain clinics that are sort of very, I would say, legit in the sense that they really try and focus on non-opioid prescribing. They focus a lot on procedures like injections of things like steroids and local anesthetic to address pain. Also things like acupuncture and massage are sort of part of pain management clinics. Sometimes you have those sorts, and certainly one of the pain practice the big pain practice in the Sinai system takes that kind of approach. But then you also have the pain management doctors who sort of declare themselves sort of pain management in the community. And I find a lot of those ones tend to not necessarily come from a background of say anesthesiology or pain focus. They haven't necessarily trained in pain. They're sort of maybe an internist, or even sometimes I've seen doctors who are psychiatrists like operate a pain management clinic, which is a bit odd. And those are the kind of practices that we see more of, the sort of sketchy prescribing, still lots of opioids being prescribed out of those clinics, and sort of a lot of inappropriate prescribing. So you do have a spectrum. Like you have the ones that I'm assuming you're sort of pointing to, the what I described firstly, like the Sinai clinic that's going to work with a lot of other non-opioid focused sort of means. But we have that spectrum here. And so it's a bit of an interesting one. So I don't know if that fully answered your question, or if you want to ask anything more specific about that.
Oh, no, thank you very much.
Okay.
Yonina, hi, it's your dad.
Hey.
Great talk. Could you could you stop the screen sharing so we could see you and all the other people?
Sure.
And could I make I guess ask a question and make a point? I think one of the previous people who made a question about doctors overprescribing pain medicines. Unfortunately, I think there's been the pendulum has, in some instances, has swung too far. And there are people with legitimate medical conditions who could very well benefit from narcotics properly prescribed for cancer pain, for arthritis pain, who are afraid because there's been so much in the newspaper and the media about getting addicted. Some people with advanced cancer don't have to worry about getting addicted because of their shortened lifespan. But I think I'd like to not maybe just raise that point that there has been, in my view, in some situations, a bit of a swing too far.
Yeah, well, I just talked about that, but I'll reiterate that. I think you're absolutely right that there is this and even more so, I find in the US maybe than in Canada, this sort of fear to prescribe opioids, and this because of sort of people feel that they're being watched and monitored, and that they're so afraid that people will become addicted, and that so they leave people in pain crises. And that's where I find there needs to be close collaboration, and I'd advocate for care coordination. And I tend to do a lot of that at Reach. And I can give you sort of a couple more details of that specific case I mentioned about the patient who I worked very closely with oncology and palliative care. And that was a case where the patient was stable on methadone, but it was very high dose methadone. He was not using, but had stabilized before I had started working with him. Several years before, he had stabilized on a very high dose of methadone. And often what ends up happening is once patients reach a stable dose of methadone, they often just stay at that dose. I didn't really go into detail about this in my talk, but sometimes there's a question that's asked, well, how long does a patient need to be on a medication like buprenorphine? And just to clarify for everyone, buprenorphine is Suboxone. Suboxone's the trade name for the active, buprenorphine is the active medication. Suboxone is often known, and it's often, I think, portrayed in the media as Suboxone, but Suboxone is a combination of buprenorphine and naloxone together. Really, that tends to cause a lot of confusion for people about what the naloxone is there for. Naloxone is there just as a deterrent to inject it. If it were to be dissolved down and someone were to try and inject it, the naloxone would be active and it would put them into immediate withdrawal. Whereas when they take it where they're supposed to, which is under the tongue, only the buprenorphine is active. The naloxone part gets completely broken down and metabolized. These medications, so generally once you get to a stable dose, you tend to stay there. And as I mentioned in the beginning, these are long-term treatments. And so we tend to sort of continue. If it's working, we don't want to don't fix what's not broken kind of attitude. And we tend to, if patients are open to it, we tend to leave them on the medications unless they want to try and taper off. Unfortunately, relapse rates are extremely high when we taper them off. But this, so going back to the story, this was a patient on high dose methadone. He was diagnosed with already stage 3 prostate cancer. So when he was diagnosed, he was already well into his disease. And I could identify from the oncology notes that there was already this question and concern about, because he was already expressing some pain, because he was already at this point starting to have metastases that were causing him pain in his body. And I could see in the note in the final assessment and plan from the fellow who had seen him in clinic that they were going to refer him to supportive oncology, which is sort of palliative care, to help deal with the pain aspect. Because he was already on such high dose methadone, it was going to be a tricky thing to be able to address his pain as well. And this is where that collaboration was started. And I worked closely with the palliative care and the oncologist to create a scenario that basically where I advocated for this patient's pain management. So as his methadone provider, I sort of took it upon myself to sort of make sure that he was going to get the pain management he needed and that he was not going to be stigmatized because he was on methadone. And there tends to be this thinking as well, again, with sort of a lack of understanding and education about methadone, is that, oh, well, they're on methadone. They don't need any extra pain management. They're on methadone already. Methadone's an opioid. They don't need anything more. And that's false, because remember from the video that methadone is keeping his body in a sort of a state where it's normal, basically. As soon as you're to take away that methadone, he would go into withdrawal. And similarly, if you add in acute pain into the mix, that methadone is just keeping him at his baseline. That is not going to address any new pain. And that's where patients need additional pain medication to address pain. And so I think that his case is if it had just been left, or there's many others like him, unfortunately, where their pain does not get managed. Unfortunately, also, there's an attitude of a lot of palliative care teams. And in fact, in the Sinai system, it used to be like this until we've had some wonderful palliative care leaders that have really kind of taken the lead over the last few years to address some of this collaboration. But it used to be that if a patient was diagnosed, say, with cancer, and they were sort of referred to palliative care supportive oncology for pain management, if they were using, so pain management and palliative care would basically do toxicology to monitor to see if they were using. And if they were using, they would stop prescribing opioids for them. And then basically a situation where the patients who are often near the end of their life in severe pain, obviously going through the emotional and difficult challenges of the process of potentially dying, they were having their opioids taken away from them and basically being like kicked to the curb. And it's just sort of, when you think about it, it's sort of devastating to think about. Here's someone who just needs so much, and now they have to go find their pain medications on the street and then maybe overdose and die because it's not a real oxycodone, it's fentanyl. So this is where certainly we need more advocacy and collaboration between providers to deal with these difficult situations. And his case worked beautifully. I'd say it becomes more complicated in situations where people are still using. So in his case, he was stable, he was not using. And I was able to kind of split up his methadone dose to allow it to work more as a painkiller. And also the palliative care team added in oxycodone to help manage his pain. And his pain remained we were able to kind of stabilize his pain throughout the progression of his disease because of this close collaboration. And I think that kind of thing needs to happen more in these sort of challenging cases, because they are often very difficult. Like, what do you do when patients are still consistently using, but they may have pain? There isn't an easy answer. It's a gray area. It's very much a gray area. And I think it often takes a lot of effort and collaboration and sort of negotiating a bit with the patient and back and forth. And it does take a lot of effort and energy, but I would argue it's worth it. But I think those are the kinds of things that need to happen, as an example, to kind of get providers to kind of engage more in potentially treating with opioids.
I just wanted to say, oh, sorry. I just wanted to say that I didn't mean to criticize doctors. You know, you shouldn't be afraid to prescribe where people need the opioids, but you have to be careful. It shouldn't be prescribed for things where you can use non-opioid medication. That's it.
Absolutely, absolutely. And I think that sort of the WHO has what's called a pain ladder. And I think that strategy of sort of starting with non-opioid medications like Tylenol, ibuprofen, so anti-inflammatory medications, before stepping up and getting into the bigger guns is always generally appropriate. Also using, as someone asked about the sort of non-opioid modalities of pain management as much as possible, working with those. There's other medications that are non-addictive and non-opioid that we can also work with besides Tylenol and things like ibuprofen that help sometimes with nerve pain or other things. Sometimes we can use patches like lidocaine patches. There's lots of other things we need to think about, because at the end of the day, again, pointing back to that video, that clip from the beginning, the problem with opioids is that often, because you develop a dependence to them, if you're taking enough of them, you need more to get the same effect.
Right.
And so we have to always be very cautious and make sure that we are appropriately prescribing opioids, because they're not always indicated. Sometimes they are, but often they're not. So I think we have to remember that we want to try and work with all these other things maybe first, and really leave opioids as a last resort if things aren't working very well.
Do we have any last minute questions that we want to throw out there? I know we've taken lots of Dr. Mar's time, very generous.
And yeah, thank you for staying with me for this time.
Misha, I'd like to ask Dr. Mark, just briefly, a great ending note. As I recall, you told us about a famous desk that you're sitting at, and your clinic is at the Lower East Side, correct?
Yes.
Do you want to sort of connect the dots where your great-grandfather, when he first came as a baby through Ellis Island, what street he lived on and where your clinic is? So it's Bashir.
Yeah, I was thinking about starting off on that note about how it sort of feels kind of interesting to come full circle in a way in my ancestry, and because where I work in the Lower East Side is an area of Manhattan where a lot of the Jewish immigrants had come into, and a lot of the tenements, so those famous sort of New York style apartment buildings with the staircases on the outside, the fire escapes, where they had these tiny little apartments that packed sort of dozens of people into them, where sort of a lot of Jewish immigrants, Italian, Irish immigrants came to that Lower East Side. So certainly some of my family started out there, probably just right around the corner from where I'm working. So I'm on, if people know New York, I'm on Delancey Street, where the opioid treatment program is, on the corner of Essex. But right around there, some of those streets like Orchard, Ludlow, those are the streets of the Lower East Side where the Jewish immigrants had lived. And there's still not so much that that's not the area that a lot of Jewish people live anymore. But certainly some of the famous Jewish sort of establishments are there. So Katz's Deli, there's Yonah Schimmel's, which is another famous spot. There's also Russ and Daughters appetizing store. So these are all institutions really that have been around for at least 100 years. They're all sort of around the corner from me. So it is kind of neat that, yeah, really kind of to be back in this area where some of my family first started.
What an amazing way to end off. Thank you so much, Dr. Mar, for taking the time out of your busy schedule to be with us here at Breakfast Club. As you know, your Temple community really appreciates it. So another exciting talk next week. Please join us in person at 10:15 a.m. And the speaker will be Dr. Rhoda Hassman, who will be speaking on why Canada's treatment of Indigenous peoples is considered a genocide. A bit of a different topic, but important as well. So we hope that you can all join us in person next week.
Thank you so much for having me today.
you so
Really
much.
happy to be able to share my work with you and some of my thoughts with you. So thank you all so much for joining.
Thank you.
Thank you.